Great. Good evening, everyone. Welcome. My name is Pei Shoinkai-Arwele, and on behalf of the Tompkins County Human Rights Commission,
My name is Pei Shoinkai-Arwele.
it is a pleasure.
And on behalf of
Hey, can you mute your YouTube page that you have open? I think that's where that audio is coming
I'm sorry.
from.
Okay, I think I was on the YouTube page. It's a pleasure to welcome everyone to this evening's community conversation titled Biased Treatment, Women's Experiences of Discrimination in Healthcare in Tompkins County. As we gather, we acknowledge in empathy and solidarity those who suffer violence, abductions, and abuse, and are without medical help in various crisis zones around the world. The struggle for the protections of the vulnerable must continue both locally and globally. This is the first in our 2024 Unmute Yourself series, a set of informal hearings and community conversations that extend our understanding of the experiences of residents regarding rights violations and issues in the healthcare system, in the workplace, in the school systems, as well as in housing, issues of homelessness, and the experiences of immigrants in our community. We invite you to share your comments, your experiences, and questions in the comment section, and our commissioners will be reading and drawing on those stories to help us provide policy advice and recommendations to the county legislature and other agencies to help to improve the quality of respect for human rights and dignity for everyone. I'd like to thank all the speakers who will be sharing their experiences and expertise with us. Their names are listed in the program description on YouTube. These women understand what it means to experience bias as women, and many have additional and intersecting layers of bias treatment because they are also women of color, Black women in particular, women in the medical profession, because they might be older women, younger women, LGBTQ identified women, immigrants, or economically marginalized women. As you write your stories in the comment section, we ask that you do not name any practitioner or specific practice. This will provide you with protection from legal liability and also ensure that everyone has a right to fair hearing and to due process. We ask that you trust that this official recording of the event tonight is available on YouTube, so you do not need to use your personal devices to record this session. If you wish to speak further with us regarding a specific experience, feel free to write the Human Rights Commission of Tompkins County and attend any of our monthly meetings, which are open to the public. We currently meet via Zoom on the second Mondays of every month, and our email is hrc.tompkinscounty@gmail.com. We've posted this in the comment section. We'll be glad to send you a link to join our meeting. You can also reach out to Dr. Clark and the wonderful staff at the Tompkins County Office of Human Rights for guidance if you wish to file a complaint about a specific violation of your state's protected rights. And their phone number is 607-277-4080. Now let's talk a little bit about the topic of this event tonight. Numerous peer-reviewed studies have established that there is widespread gender bias that affects how the healthcare system works and has a serious effect on our health outcomes. You will find links to some of these studies in the comment sections of this live stream. And I want to share with you a few summary findings. If I may, I will share, a small documentation with my slides with you. And that might help you to give you an idea of how extensive this crisis is that we are talking about. Some of the findings have been particularly troubling. For example, in 2020, a United Nations global report established that close to 90% of all people have some form of conscious or unconscious gender bias against women. These explicit or implicit prejudices affect medical judgment and behavior, including the interactions between patients and their care providers, the nature of medical research, and the sexist treatment of female practitioners. And such discrimination breeds dangerous inequities. For example, a 2018 article in the Journal of Pain Research and Management found that doctors often view men who have chronic pain as being brave or stoic, but describe women with chronic pain as emotional or hysterical. Other studies show that women's reproductive health is negatively impaired by such prejudices, as doctors and nurses are more likely to ignore complaints of pain by women during labor and childbirth, IUD insertion, or even in treating those suffering from endometriosis and other illnesses. Studies have also found that doctors were more likely to treat women's pain as a product of a mental health condition rather than a physical condition. In some studies, when middle-aged women had symptoms of heart disease, such as chest pain, they were twice as likely to be deemed to be having psychological or mental health issues than men who displayed those same symptoms. Yet another study of over 169 physicians and dentists, they described women as exaggerating their pain. And consequently, numerous studies indicate that women are more likely to have their pain or their symptoms misdiagnosed or completely dismissed by medical professionals. Women with chest pain were found to wait almost 30% longer than men in emergency rooms to be evaluated for a possible heart attack. In spite of existing protections by law, we also find that LGBTQ identified people face disturbing rates of healthcare discrimination, harassment, and humiliation. And some talk about being turned away by hospitals, pharmacists, and doctors. Gender bias also has created a culture of sexism, bullying, and harassment towards female healthcare professionals and staff. This has been covered in numerous investigations, including a 2019 British Medical Association report, a 2020 US National Survey that was published in the Journal of Women's Health that found that age and gender-based discrimination, harassment, and salary inequity persisted through the careers of established women doctors. When it comes to issues of race and gender biases, when these gender biases are overlaid with issues of racism, the situation becomes truly dire for women of color, Black women in particular, for women in precarious economic situations, and for immigrants. Much of this has been documented by the US Department of Health and Human Services that found that there were numerous examples of health inequity for people of color in the United States. By the time COVID hit us, Black people were 3.57 times more likely to die from COVID than white people, while the risk of death for Latinx population was nearly twice that of the white population. The studies are just overwhelming. Getting ready for this event, I was so troubled by some of the facts that we find, including the fact that Black children, for example, even suffer the consequences of these kind of prejudices. And the prejudices have been studied. For example, a 2016 NIH published study that surveyed White medical students and medical residents found that about 73% of them held at least one false belief about the biological differences between races, including the false notion that Black people have thicker skin, less sensitive nerve endings, or stronger immune systems. So consequently, this has led to Black people often being provided considerably less pain relief, taken less seriously when it comes to critical health conditions. These are some of the issues that we're going to talk about today. The fact that children suffer from the consequences of such beliefs, that you and I, women, our sisters, our aunts, our mothers, and our daughters suffer from these hidden prejudices. I'm shocked when I read about the study of nearly 1 million children diagnosed with appendicitis that revealed that relative to white patients, Black children with appendicitis were less likely to receive any pain medication for moderate pain and did not receive appropriate treatment for severe pain. Well,
Hey, your slides are cut off a little bit. Sorry, I was asked to intervene.
oh, I see. The slides cut off?
They were cut off on the left side a little bit.
Thank you. It's okay.
Okay.
We'll just continue from there. Thank you. I'm not sure why that was happening. But anyway, these are some of the issues that bring us to this event today. And I am excited that we have such a wonderful, wonderful group of women who are able to expose all the different facets of the challenges that we face. I'd like to first introduce our first speaker, Teresa Fulton, who is a member of the Human Rights Commission and the coordinator of the Mutual Aid Tompkins Food Sharing Cabinet. Teresa, thank you for being here with us.
Thank you. I have notes. So I had a number of experiences in relation to the same condition. As it turned out later, I had not only endometriosis, but adenomyosis, which meant that my uterus was actually adhered to my abdominal wall. So I was in, you can imagine, excruciating pain and also nonstop bleeding 24/7. So I went to a number of doctors to try to get relief. The first one did a laparoscopy and said to me, you have endometriosis, but it's really not enough to be causing your pain, which told me, I'm a scientist, by the way, and of course had already done my research, which told me he had not done any research because there is indeed no correlation between that at all. The next doctor I went to didn't want to give me a hysterectomy, despite the fact that I was 35 years old with 2 kids and divorced, because he said I might still meet a man who wanted more children. So I continued my search. The next doctor I met told me that I needed counseling to figure out why I was imagining that I was in pain. I said, am I also imagining the blood? I was bleeding 24/7. And he said, that's just a hormonal thing. We can fix that. So the next one that I went to had me try, and this was a woman, doctor even, had me try a medication, one medication, it didn't work. So she said, well, I don't think that shows that you don't have endometriosis, and I'm very sorry, but there's some people that doctors just can't help. And she refused to give me pain medication because she said I was going to have to learn to live with it. On the way out, my husband went to the front desk and said, we refuse to leave until we get pain medication. And of course that worked because he's a guy. While I was waiting there crying in the waiting room, a midwife from that same place came out to me. She handed me a scrap of paper and on it was the name of a doctor in Binghamton, New York. And she said, this doctor will help you. Note that she worked in the office of the person who said they could not help me. That scrap of paper was a doctor who ended up being able to help me. He did not do any test, no scans. He just believed me. He said, I can tell you're in pain. I'm scheduling the surgery right away. And I was pain-free ever since. I will say I did write to the Cayuga Medical Center Board of Directors and said, I think many of your doctors need more education on women's illnesses and diseases. And they did write back and very sympathetic. obviously I was just done and I did not follow it up after that, after the list of experiences that I had. I am pain-free to this day. But yeah, we need doctors to have a little more education, especially endometriosis, and adenomyosis is a little more rare as well. Thank you for listening.
Wow. Thank you so much, Teresa. I cannot believe, and I can believe, but it still shocks me and saddens me.
Imagining that I was in
Just
pain.
imagining it.
Yeah.
It's just overwhelming.
Unrelated to the bleeding. I was
Oh,
just imagining that I was in pain. Yeah.
oh my goodness. And I think later when we're having the Q&A, one of the questions that has been sent actually is that why, is it that we are worn out? Because at a point in time, women get to a point that they just get tired of fighting. And so we kind of end up self-silencing. And, how do we kind of walk through that and out of that? Maybe it's one of the things that we'll be able to discuss. But thank you so much for sharing that. And I'm delighted now to call on Karen Brown, who is an ageism and health literacy advocate, serves as the gerontology programs manager at Ithaca College, and has worked incredibly in multiple community programming across the county. And I have to say that I met Karen because of the very excited tributes from some of your students who said, you have to speak to Karen and she needs to be on this program. So thank you for joining us.
Thank you. And I will just do a quick shout out to the students this semester that I've had are probably the most top-notch students that I've had the pleasure to work with. And so they make it all worth it. Originally, I had shared some of my experiences with the students as personal as identifying as a lesbian and my experiences. But I want to first talk about, because I want to make sure I get it in here, is about ageism. And it wasn't until I started to work at the Gerontology Institute that I even really knew what the word ageism meant. And it's so important that we think about it in healthcare. Age is also being considered a social determinant of health. Our older adults are at the highest at risk of having low health literacy. And it shows forms in both implicit, overt. If we want to look at overt signs of it, when COVID hit, we were seeing that some hospitals were prioritizing young people over the older folks with getting treatment. We see it as implicit, where somebody assumes if somebody's speaking slowly that they're cognitively delayed, they interrupt them more often. And even in the way we talk about it, we know that our population is going to double from 49 million 65 and older in 2016 to their estimating in 2060 that we'll have 95 million people over the age of 65. And how did we describe that? The silver tsunami, that is going to wipe out everything. Not talking about the strengths that we're going to find from having such a, the knowledge and the wisdom of folks, but rather wanting to focus on how, of course, older people are going to just drain the systems. And then that in itself is biased. But as far as with women, I'm going to kind of shift over and talk about women. And as we age, one of the things that in particular that we see is if you look at menopause and sex life, we are seeing bias towards women that age and when they become no longer able to bear children. All of a sudden we sort of, a lot of the health practitioners just shrug their shoulders about what's the difference. Yet men have a lot of medication, Viagra, those type of things to help them with their sex life, yet it's not the same. And a lot of women suffer, much like the speaker before us was talking about. So we're seeing a lot of bias happening with women as we age. viewed as frail, and not, needing to be as active, those type of things. The one thing also that I just wanted to quickly mention is that the other thing that shocked me when I came to the Gerontology Institute is that I learned a lot about the education that our health science and health professional students have. And I was always under the assumption that I knew that students did a pediatric rotation. I assume that people in med school and those type of things had specific rotations and things that dealt with older people. We do not. That is not something that is a staple of that. So what we find is a lot of health practitioners and people who serve older adults unfamiliar with a lot of the things that are happening, as well as making assumptions. And one of the things we usually say too is, once you've seen one 80-year-old, you've seen one 80-year-old, because we do not all age in the same way. And I think it's really important that we realize is that, you can have somebody who's very active, very much, has, is not struggling with cognitive issues and those things at 80, and yet you can have somebody at 65 who's struggling with a lot of medical issues and those type of things. So we have to make sure that we don't buy into that. With age comes a horrible decline. It is not all like that. We actually know that studies show that most people, as they age, the paradox of aging shows that we're happier, more satisfied with our lives than when we were younger. So we need to make sure that we're exploring how are we going to educate those who are already in the workforce, as well as how do we help our students, as well as community to do that. And part of my job that I got to do with Ithaca College was work with the gerontology, the Finger Lakes Geriatric Education Center, which actually covers 25 counties in New York State. And it helps identify competencies and trainings and those type of things to help those who serve older adults to better enhance their lives by providing training to improve those interactions and to help people understand. We have older adults who are over-medicated. Statistics show that between the ages of 65 and 79, that people are on 14 meds, and once you hit 80, average shows that you're up to 18 medications. Imagine trying to juggle 18 different meds. The hard part that we have then too is that we do not have enough geriatricians in the United States. We currently have less than 7,000 geriatricians, and only half of those are practicing. Currently in the United States, there are only 250 this year geriatricians in the pipeline for the whole entire country. Think about that number. And so why I put that out there is that when you start to see multiple doctors and cardiologists, maybe you're seeing a pulmonologist, maybe you're seeing a primary care, maybe you have an osteo, maybe you have an orthopedic. So all these people are prescribing medications, and yet are not necessarily all communicating. So we know that where a lot of the issues come in is 1 in 6 hospitalizations has to do with medication adherence issues or a reaction to it. So there's so much that goes into this. And shifting, I know I'm looking at the time to make sure that I don't go over, but there's so much that I'd love to share that I can't get all in here, but I have 2 books that I think would be great for people to take a look at. One is Breaking the Age Code from Becca Levy. And one of the things she'll ask is, ask me about the 7.5. And we know that our beliefs about aging can actually extend your life for 7.5 years. And then there's also the other book is Ageism Unmasked. And I would just highly suggest checking out both of those to learn more about that. But I do want to talk about some bias that I've seen and experienced in Tompkins County from providers that I respect, that actually shocked me because they're providers that I know have a really have vested in older adults. So even the best intentioned can sometimes still be participating in some biased situations. And one of those, my wife is 18 years older than I am, and I've been with her for 30 years. And so lately in the last 9 months, she's started to have some cognitive issues. She started to have where she was falling. There's been a whole kind of bunch of things that have been happening. And one of the suggestions that we make for older adults when going to the doctors is like to take somebody with you so that you can better, so that they might take notes or you help you remember. And I couldn't make it to the appointment with her. So we had made the thing that she would call me on her phone and put me on speakerphone. And one of the things that I do health literacy, so I'm always looking at the doctor's forms and I want to see what's going on. And one of the questions had to do with, it was a depression screening. And so I was really surprised that one of the answers was she hadn't gotten a lot of joy out of life. And so I had brought that up, and the physician, I don't know if she remembered that I work at the Gerontology Institute or not, told me that lots of retired people like to not do things and just want to sit around, because I had said I was, concerned because she wasn't doing her activities and those type of things. And so to hear lots of retired people don't feel like doing things, to just dismiss that depression, that issue, was a little upsetting, especially when she said, and I would suggest that you maybe reach out to Family and Children's and maybe learn more about the aging process. So it was being kind of completely brushed off as an aging issue. So we see that, and with time, I will end my comments because I could go on and on about some of these things. But we definitely, women who are aging, definitely see a bias with their healthcare. And so thank you for asking me to talk tonight. I really appreciate
Thank you so much, Karen.
Thank you,
Appreciate
Karen.
your talk, and that's really useful to adding to our understanding of ageism and the general struggle for women. Without further ado, I'd like to call Anjanette Brown, who is extremely strong human rights advocate and a substance abuse counselor. Angie works at Cornell University and has worked to support women and children in desperate situations. And Angie, it's a pleasure to have you sharing with us today. Please go ahead.
Thank you. So I am a mother of 3, and my youngest child was born here in Ithaca. So I kind of know what's happening, know what's going on, when you're feeling those Braxton Hicks contractions, or you think this might be it. So this particular evening, something didn't feel quite right. So I went ahead to the hospital, and they checked me out, kept me for a little while, and it's kind of waited. And the nurse had, come in and out, asking me questions. I'm answering the questions. And another nurse had come in and was flipping through my chart and said, so this I see what's happening here, and something along the lines of, this isn't your first rodeo, because this was my third child. So of course I kind of laughed and said, well, that is true. And the nurse said, well, you would think that you would know what's going on if this is your third child. There's nothing wrong. You can go home. So I felt incredibly dismissed. I felt a little embarrassed. Kind of gathered my things and just went on home and just thought, wow, that's okay, that just happened. So I, went back home, waited, and then of course the next time it happened, I didn't do anything. I just waited, it went away. This other night, I just felt it happening again. And I just thought, you know what? I was so embarrassed and I felt so dismissed that I'm just going to wait it out. I'm sure it's just, it'll be fine. It'll be fine. And it just got worse and got worse and got worse. Of course, the labor progressed. I was definitely in active labor. We rushed to the hospital. I could hardly speak. I definitely knew, this was it. I walked into the emergency room and the person at the desk, as I'm doubled over and couldn't really speak. And my husband at the time was trying to say, she's in labor. What do we do? Where should we go? And then the person at the desk just said, well, up to the third floor, down the hall, something along those lines. And again, I just thought I was going to die because I am in active labor and clearly going to have a natural childbirth at this point. And everyone was just staring. So I was thinking, can I get a wheelchair? Can somebody assist? What am I supposed to do? I remember waiting for the elevator and people were just walking by, just watching. And I just thought, I cannot even breathe. It was just, so in such pain. And so we get to the third floor and I remember thinking, just put one foot in front of the other, just put one foot in front of the other. And the nurse at the very end of the hall was just waving me, come on, come on, come on, keep coming, keep coming. And I just thought, you've got to be kidding me. Meanwhile, as I'm walking, I see this, janitor who is standing there, had just finished cleaning and my water breaks right in the middle of the hallway. I can feel everything. No sooner did I get to that room and get myself situated for keeping it a little clean, my son was born. It was that immediate. So I think it took me a while to process what had happened and to understand really why this happened after having these very fruitful conversations like we're doing now with the Human Rights Commission and other organizations, to just say this cannot ever happen again. It just has to stop. Yeah.
That is quite
Wow.
a story. I'm telling you,
Yes.
I'm listening to you and my blood is boiling. Unbelievable. So
Wow.
indifferent, so cold, so unprofessional. That is
Mhm.
so, I'm so sorry you had to go through that, especially having a baby.
Yeah.
That's outrageous. Outrageous.
Yeah, thank you.
It is just so painful. Angie, thank you so much for sharing that. And the first time you spoke about it, I just thought, this is exactly what has to change, and when we look at the rates at which Black women are more likely to die from pregnancy-related issues, then some places it's 3 times as much. It has to be transformed. So thank you for sharing that so much. And thank you, Peaches, for speaking about this and how, just the emotional response. And actually, I would like to invite you now to speak with us and to introduce you, Peaches.
So
Peaches Gillette is a counselor, incredible woman, a counselor, educator, a human rights commissioner, a longtime community builder, and the founder of Diversity Rising. It's wonderful to have you, share with us today. Thank you for the work you do in prisons with various populations. Looking forward to hearing what you share.
Thank you very much. You can see it in my face. I am so disturbed by, in general, the way we treat one another, let alone how we treat people of color and women of color in the medical profession. We don't have any alternative but to go and get help. And we are met with this nonsense that you're describing that really puts us at risk. It is not a joke. You could have passed away. You could have lost your child, God forbid. And I don't understand why people can take that so lightly. So it's very disturbing to me. And I've had several of those. When I first came up here about 7 years ago, I was treated very badly I have a bad leg. I had a broken leg and it needed new surgery. And people were just blowing me off about how painful it was and that it needed to be re-x-rayed and maybe reconstructed. And I just couldn't get any help. And I ended up getting sepsis because of the neglect, ended up in one of the nursing homes where they didn't have the equipment that they were supposed to use on my leg. The nurse who was supposed to give me medication told me she was busy and just completely ignored me. And it is endless. And I have to tell you that I even had trouble with a chaplain who said a couple of racist things to me when I was in the hospital. And it just blows me away about just in general how we treat one another. And I'm really glad that we're having this forum because it is completely ignored. And I think that people don't know. And even when they do know, they don't take it seriously. They're thinking, oh, that's just those women complaining about, women, they just complain. They're oversensitive, right? They're over emotional, they just complain. And like Pei is saying, that we are killing our people because of this. Our women, we're allowing to die because of this. And people need to constantly speak up about this and to stand firm. Now I've kind of taken on the position that I am more forceful when I'm at the doctor's office. I had gotten endometrial cancer last summer. And the examination, who was a woman, which was a sad thing to say, I was told, like, no, we're going to give you something to numb you and it won't be painful. And I have to tell you, it was like a medieval movie. It was so ridiculously painful. And that was the second clinic I went to. The first clinic I went to, I was 5 minutes late and the woman wouldn't even look me in the face and told me, I'm sorry, you can't have your appointment. I'm dealing with cancer. That's not what you do. And so it's constant. And sadly enough, it's people you think you could trust. It's other women who have taken on this mode of operation. And it's the medical profession overall that just does not care enough, and I'm glad that we're here together trying to share these stories and create some movement in making people more aware of what's going on,
As you spoke, I was just hearing multiple, studies that indicate this is a widespread problem. And I think what hits home is that, we live in a county where we have tried to build this beloved community, a community that cares. And it's often like a shock for many people in the system to realize that we are very much going through the same documented forms of prejudice and abuse.
Yeah.
And that women tend to be very kind often in trying to overlook it until it becomes impossible and it becomes, critical to your health. And I thank you for saying the importance, which we need to discuss later. How do we speak as women with a clearer voice? How do we take on that place of not being diffident about our health and being more confident in voicing the fact that you know your body, you know what you're going through? And I was also very glad that you mentioned how women in the profession often have taken on this system, because one of the earlier studies, which I was, citing, that surveyed about 169 doctors and dentists, 40% of them were women practitioners who also said women are exaggerating their pain and took the pain of men more seriously. So it hurts so much to know that, this is what you have gone through with such grief, and you are someone who goes through it with a smile, giving all the time. It should not be taken for granted.
Yeah. I
Thank you
had a
so much.
woman doctor in New York when I lived in New York tell me I had a blood condition and told me that I should just get a hysterectomy because I wasn't using those parts anyway. Could you imagine somebody saying, I thought it was a movie I was in. I couldn't even imagine somebody talking like that, you know? It is rampant and it's really disturbing. And it's very difficult for people in general to speak up for themselves because you do feel intimidated, you do feel embarrassed, you know, that's one of the things, and you feel like, well, I don't have any power over the people. And so that's why we really have to band together and say, and even if we have to go with one another, you know, to clinics just to say, you know, there's a force in numbers.
Yes.
You know, and we're not going to deal with this anymore.
Yes.
You know, the simple thing that somebody wouldn't offer you a wheelchair is just beyond me. I can't even believe that, you know. Yeah, it's really a horror story. It really is. And I feel really my heart goes out for people who haven't figured out how to defend themselves and in fact who will stop going to the doctor altogether because they don't want to deal with the nonsense. And I've had friends who've done that. They belay it and belay it and belay it, and then it rolls into a crisis state, you know.
I know.
But I brought out my Brooklyn self. I was like, no.
I think that is one of the biggest consequences. I find myself guilty of that. And so I'm glad you mentioned that because people keep saying, why do immigrants, why do women of color delay? And we need to understand that some of these treatments, some of these attitudes is one of the reasons why people don't want to go. And even our children, you know, wonder that what's the point of going to the doctors?
Yes.
So thank you so much, Peaches, for sharing this. I really appreciate, we all appreciate your thoughts and your words here.
You're
and you're
welcome.
sharing these experiences.
Yeah.
So it seems that, you know, like our friend Anna is not able to make it here, and she's someone who works with immigrants. And however, I will share a little bit of my experience now. And I do apologize to those who are listening on and who did not see the slides I was showing earlier. I have no idea what went wrong with the slides. I will ask this question, whether anyone can see this one slide I will show briefly. And if it's cut off, let me know. Is anyone able to see this?
I can see it very clearly.
You can see it?
Yeah, there's a part that is a bit cut off.
There's a part cut off?
Yeah, just from the
end in November.
End of the November,
November, okay. I just wanted to, I think it's just the visual and, you know, not so much the, I will try and go through very quickly a few things here, and I will take off this slide in a minute. But what you see in the first green column there are dates. And the first, you know, column is, it says husband, that's referring to my husband. And then female, PSA, that's me. And I decided to use this little way of coming to grips with the gender bias. Now, my husband and I, we've had the same family practitioners for about 2 decades now. And, you know, over that time, we've been generally treated with a lot of care. So I am not trying to say that this has been a practice that has not been caring and considerate about our health. However, late in 2019, it happened that we were both placed on medication for high blood pressure around the same period. This was towards the end of 2019. And I saw a startling difference in the process. And as you will see, I'll remove this chart now. But if you look at the first column, which refers to my husband, you can see on meds, on meds, on meds, on meds. And in the last column, that's for me, you see a lot of detail about what it took for me to get meds. Wow. So briefly, let me stop it to make it convenient. Briefly, around November 7th in 2019, I was at a specialist office with something that didn't really have to do with my primary care. And they took the typical BP reading and found that I had very elevated blood pressure. They were very worried about it. It was the second such high reading, and they asked me to see my primary immediately. And as Peaches had said, I didn't. I started doing, readings at home and documenting that. And so I had two doctors, very high reading, and then a bundle of readings at home. Then I had a third reading at the doctor's offices. And we're talking about readings that were like at a point 169, for example, over 104, which later I realized that some of my readings were in the toxic BP zone. So I had been from November 7th, seeing the doctors and so on. Then that week, my husband stopped at the grocery store or at some, casual thing, and he did that self-test you do. He saw that his BP was high, and so he went to the doctors. And that same day, they placed him right away on blood pressure medication. They did a reading, and it was the same, and they put him on medication. So he started urging me, since my readings were now about 5 readings that were very high, go and see the same primary. So I finally go on November 27th, 3 weeks after. I'm armed with about 3 doctors' BP readings and about 6 extremely high readings that I did at home. And I didn't see my primary at that time, but I saw somebody else in the office. And she initially gave me a diagnosis of essential hypertension. And she said that meds would be provided. After I got home, I realized that I read the summary, and where she wrote essential BP and the medication she wanted to prescribe, they changed it to discontinued in the same day. And so I called them and I said, you wrote discontinued. She said, well, I spoke with the other doctors and we decided that we'd like more testing to be sure that you actually have hypertension. So same practice, very different process. And we would like to do more urinalysis. We'd like to send you to whatever. We want to have a nurse follow up with you to check that you are doing the readings. Now, comparing, my husband did 1 reading at the pharmacy himself and got put on medication once they confirmed it the same day. And I go through this. A nurse will be in touch with you. I wait 2 weeks and no nurse has been in touch. I call them and they said, well, the nurses, they have not had time to get in touch with me. I should keep checking my readings. And so it continues until into December, mid-December, I call them. And by then I don't really care about medications, but I finally realized the shocking disparity in how we were being treated. And I spoke to them and they said, well, the nurse had been busy and so on. So I wrote a letter and I put the documentation. I put all my BP readings. I put I had 9 high BP readings. My husband had 1 and another 1, and he put on medication. So then they referred me out to somebody else who then finally confirmed on December 18th. This was well over a month after my husband had been put on BP medication before I finally was put on treatment for blood pressure. I think it was startling for me because this is the same family, a same household. The only difference is that one of us was male and one was female. And the way we were treated, the seriousness of the same, my readings were much higher than his, and were over a long period of time, but I was treated utterly differently, which I made very clear to them. A second experience that really got me is also reflected in the literature that says women tend to be treated as though they were having mental health disorders rather than biological. I traveled overseas with my family for about a week to 10 days. And because I have severe allergies to malaria medication, I asked a specialist and they placed us on a medication called Comosunate. It's a combination medication. And because I have documented allergies, I was very careful. So we had to take 1 tablet a week of amodiaquine. So we took it. My daughter started getting very tired during the trip. And I began my usual allergic reactions, hives and itching and so on. We returned back to the US and she complained of pain near her abdomen. My reactions were also getting worse. I took her to her pediatrician and they were wonderful. Shout out to them. They suspected there was a reaction affecting her liver. And so they said, well, we were going to do testing. They found that her liver, she was having liver damage. Thus began several months of crisis. And
Yes.
so they advised that the rest of us get checked out. I went to my primary pediatrician and informed them that I would like to get the same blood to rule out liver damage because I was also in an allergic reaction. And the doctor I saw treated me like I was a hysterical, ignorant Black woman who had no idea what she was talking about. It was a long battle. They had to go consult other doctors to see whether I merited being taken seriously. They put me on medications for the hives, but she made it clear that there was something wrong the way I was reacting. In the meantime, my daughter ended up in the liver transplant unit in Rochester, where her liver biopsy confirmed exactly what I had been telling them. It was a reaction to that medication. We almost lost her.
Yeah.
I did not realize that the doctors at my practice had documented that they saw it as me having a mental health issue. It was when I got an invoice from my insurance company for emotional, I'm looking at the paperwork here, emotional and behavioral diagnosis.
Wow.
That I realized,
Wow.
yes,
Whoa.
I was diagnosed as having emotional and behavioral problems. In the meantime, we were back and forth. I didn't even realize because we were making sure she was saved and rescued. The same medication that gave me, and it was my allergic reaction that made me tell them it was probably her liver caused by that drug. It took the liver biopsy weeks later when we had almost lost her, and we insisted that she be referred to Rochester, that they confirmed that it was the medication that I was talking about that caused that. In the meantime, I was written up as somebody with emotional and behavioral issues and charged for a consultation, charged for that.
Right.
You know, that let me understand that, one, it really puts your life in hazard when you are dealing with these kind of hidden prejudices. I wrote a long letter, very upset letter to the practice. And they responded by saying, well, the person on duty thought I had whatever. And I demanded a meeting to follow up on. They still haven't set the meeting to talk about that. But it certainly made me realize that we have to talk about this issue. There's a crisis, there's a problem. And, you know, I will stop here. I was sitting down and I had like about 8 different experiences of myself and other people to talk about. But this is just the beginning of our conversations. And I would like to call on Lady Ajayi, who will also speak about an episode that confirms the ways in which Black women in particular are stigmatized often, are pain dismissed, and treated with discrimination. Lady Ajayi is an associate professor who focuses on women's issues, gendered violence, and human security. And she's also a human rights commissioner. It's a pleasure to have you speak with us. Thank you, lady.
Thank you. Thank you so much, Professor Shoyinka Willie. Good evening, everyone, wherever you are in the world. I'm so grateful to be part of this conversation, very important conversation. And the experience that I'm about to share with you is my personal experience and still grieves me with so much pain and shock whenever I have to relive the experience. I catch myself asking myself, did this actually happen to me? But sadly, this is the reality of many Black immigrant women, families across the US and in the county here. I would start by going through the negative experiences and the question of urgency I experienced at the local urgent health care clinic. In 2022, precisely in February, I was on campus preparing for a final class or for the day with my senior colleague on a Wednesday, when I suddenly I began to feel dizzy, pounding headache, and I could barely have my head lifted high the way it is now. all I wanted was just to have the lights off. And my senior colleague walks into my office and saw me with my head down on the desk. And she said, "You need to go to to visit the local urgent care immediately for medical attention." She assisted me through the elevator to the car and, drove to the local urgent care. Now, upon arrival at the local urgent care, my details, it was time for me to, it was my first time there. I've just been in the US, got to the US in 2021, August 2021. So it was actually my first time being there. So a lot of documentations, and then my insurance had to be verified before I was attended to. I could barely stand. Imagine me walking in. My senior colleague supported me into the local urgent healthcare. And so I could barely stand while I was responding to questions. Do you have this? Can we have that? And she also assisted me, there were recurring questions. I was too weak. My head, I was actually bent. I actually placed my head on the counter. And then, the person attending to me, who was a male, took his time to actually go through, the entire process. And at that point, I began to question the main idea behind having what urgency in terms of when it's called an urgent local healthcare. What is, how urgent? What cases are attended to with level of urgency? Along the line also, and then after all that, I went in for my BP to be checked. So I was asked to do a COVID test and then for my vitals to be taken. The COVID test happened. Before the COVID test, the nurse said, "Oh, they do not have a BP cuff." And so my BP wasn't checked. She just went around and then she looked left, looked right, and then did used the swab for the COVID test and, dismissed me. I got to the counter at the urgent care, and then I was billed over $500. I couldn't, my mind was still trying to process what was going on. Nothing had been diagnosed, no vitals checked. So how am I being charged? Yeah. But that at that point in time should be the reality of the exorbitant cost of the healthcare. And even at my stage, being a professional, even with my economic status, the 500 was extremely high. But what am I being charged for at that point? And so I had to, said a payment had to be made. So I paid $40 that night. When I got outside to meet my senior colleague, who was curious to know what my BP reading was, I told her that the nurse told me that they do not have a functional BP cuff. She stormed out of her car and asked me to return and demand that my BP be checked.
Yes.
To my amazement, when I walked to the door, it was locked. I was told that they were done for the guy who attended to me at the counter reached out and said, "Oh, they had closed for the night." And mind you, as I was moving, I was being supported and all that. My senior colleague banged at the door hard and had to, threaten at a point. My energy level was dissipating and the headache had spiked beyond control with intense, my eyes were red, like intense, I was going through pain. My senior colleague said we weren't leaving there until a BP cuff was provided. They finally opened the door and lo and behold, the nurse brought out a functional BP cord.
Oh my God.
Cuff and checked and my BP was checked. When it was checked, it was out of control. At that point, it was 180, 140. So they lied. My pain was trivialized, wasn't taken seriously. Even with the way I was bending down and being supported, the urgency, it wasn't urgent. Immediately, I was referred to the ER. My senior colleague, she drove. She wasn't fine. When we got there and it was checked, even doctors that, at different family friends, different parts of the US were shocked. Even the doctors were shocked that at that point I had not passed out or gone into seizure. When I think back to the unfair and biased treatment I experienced at the local urgent care clinic, the fear of how my life would have passed, or how would have passed with that experience, because how I was feeling, it was like my energy was dissipating. We got there around 5:30. We left the urgent care around 8, got to the emergency, the ER, and, my BP was being checked, constantly. I could go on with the statistics, but 21% of Black women report being mistreated by healthcare provider because of their race and ethnicity. 61% of Black women say they must be cautious about their appearance to be fairly, to be treated fairly during healthcare visits. This experience helped me to further affirm the lack of attention given to the pain of Black women. The need to constantly fight for our pain to be urgently recognized and attended to, and also advocate for ourselves to ensure quality care is received. When I asked myself if I was the only one there, I would have probably gone home and just taken a painkiller and I don't know what would have happened to me. But however, 55% say that, research has shown that 55% say that they have had at least one negative experience, Black women, one negative experience, including advocating for proper care and being treated with less respect. I had to wrestle with multiple factors that were intersecting and creating multiple layers of violence and discrimination as I struggled for my life in a fragile state. My race, being a woman, my gender, my nationality, and then being an immigrant, all were just colliding, and to my experience. And this has also shown, research has also shown that, according to the KFF survey, in 2024 has shown that these biased treatments and negative experience, have made Black women seek healthcare providers within their demography who have some form of shared racial background and can understand their experiences and vulnerabilities. There are significant health consequences with the negative experiences. And Professor Shoyinka, you shared some of that as well as speeches when you were sharing your experience. And research has also shown that these factors would lead to this negative experiences worsen the health of women. Because even when I was had been attended to, we left the ER that day, 4 a.m. the next day, because I was immediately put on bed rest and they were monitoring it to ensure. And immediately I was given medication, and it was like hourly, even at in the ER, my senior colleague had to keep saying, when they asked me the pain threshold between, and despite the fact that I was covering my eyes, I didn't want the lights, to go over my eyes, and I was in so much pain. They were asking me, what's the level of pain on a scale of 1 to 10? And I didn't even have the energy. And, she was like, can't you see what's going on? And immediately they swung into action with so much, I've had the opportunity to have Black women share their bias treatment in the healthcare system in Tompkins. I've also had to advocate for some Black women within the county and also outside the county. Recently, I had to accompany a single Black mother and her toddler to the ER at midnight. He had a sore on his toe and a part of his skin was elevated. And when we got there, this nurse, who was already very cranky, was attending to him, but was going to actually pull up that skin without any care. And right there and there, and this also corroborates, some of the statistics that Professor Shoyinka really shared. And at that point in time, it was like, you can't do that. At least this child is in so much pain. He was not given any, he was not under any painkiller, nothing. It wasn't deadened. You were just going to pull up that skin and then treat right there and then. Said we needed another nurse to attend to us. I said, we're not comfortable with this nurse. It's like this nurse has an agenda to kill this boy. And we were given immediately, we were given another nurse who, with so much care and tender, took, care of him. This shared experiences are alarming, heart-wrenching, and heartbreaking. And you agree that, as we have all spoken one way or the other, that there's a need for systemic changes, but it starts from us speaking out. It's not easy speaking out Because even I myself, before I was able to even pen this down, I would say this is the first time I'm actually penning this down, my experiences. And, this bias, there's a need for systemic change. I was speaking out to create the need for systemic changes in the healthcare system to ensure equitable treatment for all patients, regardless of their race, gender, religion, immigration, status, economic backgrounds. Now, continue these conversations about these issues is vital to bring about meaningful change. Amid my intense pain, I learned how to advocate for myself and other Black immigrant women. When I find myself in the healthcare system and I see a Black woman, Black child, my ears are like, I want to know what's going on, because it's like, it's like, I know I can't save the day, but, act of speaking up, because I was privileged to have my senior colleague push me. It said, you have to fight for yourself, fight to be heard. I had to fight to be heard. I had to demand for proper quality health care. I'm grateful to my senior colleague, Professor Shoinkaiwili, for equipping me with these survival tools. I do not want to imagine what could have happened if I had gone to the local urgent care clinic alone that night. Thank you so much for the opportunity to share my story.
It's very interesting because there are things, you come in and this is not an evaluation about your personality. This is an evaluation about what is happening in your body. And high blood pressure is one of the biggest red flags to heart attacks and strokes and aneurysms and everything else. It doesn't matter how you're behaving. If your blood pressure is reading, if you to see the numbers, they need to do something about it. It's outrageous.
They actually dismissed me. They said there was no functional, and they dismissed me and billed me over $500.
$500.
It is and urgent care who tells you they don't have a blood pressure cup. What are they?
It's not possible.
Right, exactly.
When she came out and said, they said they don't, I said, what? It was obvious that her BP, hypertension was involved in what was going on. And I'm not even a doctor.
That's right.
And then to say that was one of the most unbelievable, outrageous commentaries. I cannot imagine any licensed, registered clinic claiming that they don't have that most basic. And so it was a lie. And the worst thing was that they lied. And, Dr. Ajayi, you put it so well that, there was a level of contempt, of disrespect, the immigrant experience, when they look at you and say, your accent is different. You don't know what, the standard. You don't have the expectations. And immigrants, you fight these multiple layers of bias. And it often takes us a lot of time to get to that point of saying the glossy buildings, the fine so-called looking hospitals has nothing really to do with your own experience of healthcare. And you realize that you are being treated in that way because you are marginalized. And when you now think about the other immigrants who are not even like you, you're a PhD holder, a person who knows their rights and so on, who are fighting with language barriers and cultural barriers and forms of denigration, becomes abominable. It's just unacceptable. And this is something that we still have to go back and take up, and should at least get you an apology, a written apology from that urgent care clinic to say, we recognize what we did wrong and we're committed to making sure it doesn't happen again. Thank you for sharing it in such a powerful way. I recall that when, there's this experience, I mentioned it to students, they were in shock. Literally, students were like, this is not possible. But it's possible and it happens. So thank you.
And and I'd like to say that even when I was told I had to, go to my GP, get a GP, I had to go to a Black woman, please refer me.
That's right.
And even when at that, anytime I'm going for checkup, it's like, I'm like, do I have to go? It's like that experience. Do I have to go? Do I have to? I look at the data, I'm like, is there a way I can? So I can imagine if at my level, I'm struggling with that. Imagine people that are not, and that is the experience of a lot of women who do not, and that would also make sure the health deteriorates as years go by. So this reality, they are tough.
Thank you. They're real. They're real. And I think we should just quickly mention that for a lot of people, in fact, who are people of color, who are people of their social income, low income, just to get accepted often on a doctor's roster becomes another obstacle.
Yes.
Sometimes, we've had to travel out of town to get people to even find a doctor or a dentist willing to take them on. And these are some of the other barriers that people of color, those of low income and so on have to face when trying to get access to healthcare. So thank you again. Thank you again for this. Now we are going to welcome Dr. Josie. Well, her full name is Dr. Josephine McAllister, who is an MD. She is the only MD amongst us. She is a dermatologist, an incredible community builder and advocate. When I have first met Dr. McAllister, I heard her speaking and I was blown away by the strength and her perseverance through experiencing gender bias itself in the field. And so she brings a very powerful and unique view to understanding some of what we experience as patients, but which she experiences at multiple layers and levels in terms of who she is and her multiple identities. And I'm really always grateful for how much you spend in this community in helping to support organizations and groups to empower individuals to be able to have their voice heard. So thank you for joining us. And I know that, it's a sensitive situation for you. It's your profession. And we appreciate that you have to be very careful with what you say. But thank you for the courage to speak with us about it today.
Thank you so much, Pei. Thanks so much to all the panelists for sharing so openly and from your hearts. And thanks so much to everyone for being here and for listening. In 2009, I moved to Ithaca to join my husband, a Cornell physics professor. We were excited about trading in the long commutes and high cost of living of Boston, New Jersey, and Palo Alto, where we trained at Harvard, Princeton, and Stanford, for what we thought would be a peaceful existence in a lovely college town. Liam loved his department, and I immediately felt at home in Ithaca with my sweet and appreciative patient population. I was young, idealistic, and naive. Unbeknownst to me, besides our wonderfully supportive community of patients and referring physicians, a senior male physician was also watching my nascent success. He asked me to refer patients to him, and I, aiming to put patient safety first, politely declined. The male physician would not accept that no means no, and when I continually refused to give in to pressure, he worked behind the scenes to tear down my reputation in practice in ways that still affect us every day. The early years of learning how to care for patients in the real world, run a busy practice, and work with a partner a generation older than myself were all consuming, and I had no idea of the underhanded medical politics that were about to impact me. Just as I prepared to take over the practice upon my partner's retirement, I gave birth to Elwyn, a beautiful girl with Down syndrome and multiple associated medical problems. My family rallied around to support me through this life change, which is a whole other story. At one point, while seeking medical advice for Elwyn from a senior male specialist in town, he abruptly began berating me for not referring patients to his colleague. According to him, I was sending millions of dollars of potential revenue outside of our community, which in his mind was unconscionable. I was overwhelmed with the challenges of starting a practice and managing my daughter's complex medical conditions, and I was unable to respond to this verbal onslaught with its bizarre revenue before patients perspective. It was the first inkling I had of the depth of rancor being stirred up against me. Wow. 5 years later, with Liam now having achieved tenure, our second child born, and my practice gearing up to recruit another dermatologist to keep up with demand for our services, I received a bombshell that sunk once and for all my conception of the medical community of Tompkins County as a benign environment. A physician needing funding for training had called up a local medical institution, and rather than introduce me to my future colleague, as had been the custom for other physicians in our community, they called the senior male physician and secretly signed a contract that would start a large institution-sponsored department to compete directly against my small independent practice. I met with senior leadership and many colleagues, gave multiple presentations, and spoke at length with legal counsel, all to no avail. I called the senior physician to ask why I had been targeted in this way, and he gloated that I was facing consequences for not referring to him. He started malicious rumors reaching as high as the CEO that I engaged in unethical business practices. He damaged my reputation and credibility by calling me a liar to my colleagues and threatened to have my practice kicked out of our local physician association that we have been a part of since its inception. I tried to speak up against this unjust treatment and was threatened with a slander lawsuit. His associate endangered my medical license through multiple frivolous complaints to the New York State Office of Professional Medical Conduct, which concluded its investigation by stating the care I provide is both appropriate and beneficial to my patients. Inaccurate, misleading, and fake reviews about my practice were posted to online websites from which it is nearly impossible to have them removed. My recruits, on whom I'd pinned so many hopes for future collaboration and expansion of the practice, were frightened away. When I turned to my colleagues for support, the vast majority of physicians supported me, but those who had been poisoned against me stated that I should leave town, that since I trained at Harvard, I didn't belong in Ithaca, but was dragged out against my will by my husband, accused me of starting a cat fight with the senior physician's associate, vociferously criticized my patient-centered practice protocols at otherwise collegial medical meetings, and they chided me not to work so hard since I should spend more time with my children. I highly doubt that any of these criticisms would have been leveled against a male physician. In medical lectures meant to be educational, I was called unethical and incompetent, and then studiously ignored while I had my hand raised for 15 minutes in front of the appalled audience. I had my speaking time cut short while my male colleagues were allowed lengthy, unrestricted remarks. I was called Josie in a stern teacher voice when my male colleagues were deferentially called Dr. So-and-so, and overall treated in a way that was unprofessional and inappropriate, particularly given my unique expertise in the areas discussed. With the double whammy of the COVID pandemic and the 2016 election, hatred and resentment against Asians rose in our country and in Tompkins County. My expertise as a physician and years of service to our community seemed to count as nothing on the streets of Ithaca, as I was misapprehended by some passersby as a suspect foreigner who had caused the virus. My own mother was shouted at to go home by strangers on the street, and my Asian friends and I similarly experienced rage from passersby blaming us for the pandemic and calling us Chinese as if it were an insult. We were terrified of going anywhere. Asian physicians face microaggressions and race-based challenges during the course of our training and practice, including invisibility, as professors call us by the name of another Asian student, visibility, as patients miscategorize us as foreign, particularly veterans who may associate us with their experiences in Vietnam and Korea, lack of representation when learning about health issues affecting other ethnic groups but not Asians, and lack of role models to show us how to care for our community while also perpetually being treated as foreigners in our own country. I've learned to simply say thank you when well-meaning patients ask me repeatedly where I'm really from, implying I don't look American, or pronounce welcome to America, rather than take extra time to explain that I was born and raised in Boston, that my family, just like their ancestors, immigrated here seeking freedom and better opportunities, and that my parents have contributed decades of service in the defense and teaching fields to their communities while paying more than their fair share of taxes in a country where we are still not universally welcomed, proportionally represented in elected office, or promoted at the same rates as our Caucasian colleagues. As challenging as it was to keep a business running during the pandemic, COVID-related stigma and anti-Asian hate additionally cost Asian American businesses billions of dollars in lost revenue if they were able to survive at all. Aware that my practice already lived under a microscope created by my aggressor in a time when ignorant individuals blamed the pandemic on Asians, I took every measure possible to keep patients and team members safe as our practice stayed open for those needing our care. Just as I was about to breathe a sigh of relief that we'd survived the worst of the pandemic, a high-level executive called me to, again, you guessed it, ask that my practice send them our referrals. Other local dermatologists had also expressed serious concerns with the safety of those services, but after I politely declined, I faced long planned consequences to which no other physician in our community had been subjected to date. I'm unable to go into further detail due to potential litigation, but suffice it to say that my practice would not be here today if it weren't for the overwhelming and unprecedented support of our patients and community. In conclusion, I hope my story encourages all of us to broaden our definition of what it means to be an Ithacan or even a native Ithacan. Let's reimagine what it means to belong in Tompkins County. Because when we marginalize and disregard fellow human beings due to their race or gender or both, we harm them, we harm their families, we harm those whom they employ and their families, we harm those needing their expertise and their families, and in actuality, we harm our own community. In looking back at over a decade of experience in our local medical community, I see multiple sad instances of women or minority physicians undermined, marginalized, and particularly unfortunately in a community with limited human resources that may not be easy to replace, even pushed out permanently to maintain a status quo that favors the good old boys club of senior white male physicians who work out together, golf together, drink together, and promote each other's business interests. As troubling as these experiences are, the incredible support of my patients, team members, colleagues, and all of you give me hope that we can advocate for much needed change of our broken system. First, by ensuring that multiple and not just token women physicians of all ethnic backgrounds are appointed to meaningful leadership positions, particularly at the very top of institutions receiving public funds. And secondly, by truly holding our leaders and institutions accountable in a way that is not currently possible. I hope we can work together to create an Ithaca where everyone belongs, where the marginalized are protected from the predations of the powerful, and where all who wish to join in and contribute to our community are welcomed as fully fledged members of Tompkins County. May we all lift each other up in our time of need so that all may thrive here in our beautiful community that needs each and every one of us. Thank you.
Thank you very much. I have to tell you that it just hurts me so badly. This outrageous discrimination against Asian people goes untalked about unless there's something that makes it to the headlines, and it's usually against Asian people. No one talks about the intense discrimination that goes on against Asian people, and your story is a story of being terrorized, and that is outrageous, and I really appreciate you sharing that. And if there's anything in the world that I could do for you, anything at all, I would absolutely do it.
Thank you.
Thank you so much, Dr. McAllister, and thank you so much, Ms. Gillette, because I was trying to compose myself after listening to Dr. McAllister, and I was just very emotional and overwrought because, when I think about the things that we've all been talking about today, to hear from someone in the trenches who is trying to transform that, and to know what you have been through yourself is overwhelming. And I really thank you, not just for sharing this, but for also helping us to begin to understand all the levels at which we have to fight. Understanding that even our own, when Dr. Ajayi said, it is why many women of color look for someone, a practitioner, a care provider who can understand their experiences. We often don't even understand what they have gone through their medical training, through being in a field that's dominated often by a men's club that has established a way of thinking, seeing, referring, behaving. And the very areas of change that we have been yearning for can be opposed so viciously that you then end up bearing the pain and the scars. Who takes care of the practitioners when they carry wounds like the ones you've spoken about? Who takes care of a woman of color who is accomplished? You were a past president of the medical association here. And that is incredible. You don't get there without a lot of respect for your achievements and for what you're doing. And to have that become so imperiled and you made vulnerable, it's heartbreaking. But it's a reality check that we need. And as Ms. Gillette put it, we don't pay enough attention to what has happened to people who are Asian before and after the COVID pandemic, where so much worsened for them. And I really thank you, because yours is the only, I've been in Ithaca for over 2 decades, and yours is the only practice ever that I have seen open its doors to bring people in for the community, for a picnic, for, it's unbelievable. You open up the doors, you created a practice that would allow a community to feel at home there. And I just want to encourage anyone listening that this is what changes the paradigm. What you have done is courageous, is bold. It's the first time I have been anywhere to see a doctor be somebody in the community that says, you know what, bring your laughter. I will bring a space here. I have chairs. I will put food out there for you to relax, to celebrate life. And, so you can build a relationship of trust. So thank you for all you do. And as my colleague has said, we will do everything to understand more and to fight and to stand beside all those like you who are trying to make this community a better place for everyone. Thank you again for your courage, for sharing, and a luta continua. We will work together in solidarity. And we look forward to hosting you at the Human Rights Commission so that we can learn more and be guided about what we can do to make things better. Thank you, Dr. Mika.
Thank you so much.
Thank you very much. Ooh, what an evening. What an evening. What an evening. And now our last speaker has a lot that she will be helping us to pull together, and to hear her is a treat. I first met her in person at the Human Rights Commission reception in November, and I thought, this is the person we need in this community. And her name is Charlene Holmes, and she's a welcome leader in Tompkins County. She serves as the Chief Equity and Diversity Officer for Tompkins County. And she is a reality speaker. And, I think we're going to see a lot and hear a lot from her in the months and years to come as she helps us to transform, issues here. So thank you and welcome, Ms. Holmes.
Welcome. Thank you, Paige.
Dr. Holmes.
No, definitely not doctor. You're the doctor. Oh man, I don't even know where to start. First, I just want to validate all of the women's experiences. That's first and foremost. Your experiences are true. They happened. No one should be questioning. We should believe what you've experienced, and I'm here to validate that. I don't necessarily even know where to start, but I'll start with a little bit about what I've experienced, and then I'll go into what I like to call disrupting. I like to disrupt things. Like Ms. Pei, Dr. Pei said, I'm a truth teller. That's what I sell myself as, if that makes sense, my branding. But first, I'll say when I first got to Tompkins County, it has been 8 months since I've been here. And I was looking for a dentist. I was looking for a OBG. I was looking for a primary care, just looking for all of the basic preventative healthcare opportunities that were in Tompkins County. And one of the things that I noticed was that the folks that I would meet in the community who were either Black or Latino would either be missing a tooth, have a tooth issue, and that made me less likely to go to a dentist in the area. I then had a conversation with a a person in the community who talked to me about having an issue with their having stomach pain. And when they first got here, they went and sought out help for their stomach pain. And that stomach pain diagnoses turned into a hysterectomy. I was petrified. I'm like, people are missing teeth and they're taking women's organs. Like, this is what I'm thinking in my mind. I'm like, is this the movie Get Out? I just have to be 100% transparent. I was like, I'm not going near anyone in the medical field in Tompkins County with a 10-foot pole. And I'm taking my Tompkins County Chief Equity and Diversity Officer hat off now. And I'm talking to you guys as Charlene, like the human being. I wasn't going near it with a 10-foot pole. I started to do extensive amounts of research in terms of how far I would have to drive because everything is so far from here. Would I have to go back to my hometown? Does my insurance cover my hometown? I'm thinking all of these different ways that I would be able to circumvent the experiences that I had been either seeing with my own two eyes and or hearing from folks who I was questioning about, what would it be like if I were to engage? One of the things that I also recognize is that my colleagues who are near and dear to me, they're very kind. They identify as LGBTQ and they believe that LGBTQ is synonymous, LGBTQ friendly is synonymous with Black friendly. And that is not true. So I even had to filter through that. Because I know Ithaca is a sanctuary, but Ithaca seems to be a sanctuary for certain types of people. And that is, once again, me, Charlene, not the CETO that's talking to you. So as I started to develop what my preventative healthcare would look like here, once again, I'll restate, I started to research outside of Tompkins County. One day, one of my interns heard me on the phone and I asked if there was a woman of color or a person of color who was a practitioner at a particular practice that was in our neighboring county. And my intern was so shocked. They were like, you have me thinking about doing more research in terms of my thesis and my area of academia just by that question you asked. It was very alarming to me that you would ask that question. And they asked for me to break that down. And I told them a little bit about my apprehension to seeking services, medical services in Tompkins County because of what I had seen. So gonna put my CETO hat back on. You guys got a little bit of me, the real me. And now I just want to talk to you guys a little bit about two things. One, in the National Library of Medicine, an article by Hoffman, Trawalter, Axe, and Oliver in 2016 called Racial Bias in Pain Assessment and Treatment Recommendations and False Beliefs About Biological Differences Between Blacks and Whites discussed that beliefs that Blacks and whites are fundamentally and biologically different have been prevalent in various forms for centuries. And in the United States, these beliefs were championed by scientists, physicians, and slave owners alike to justify slavery and their inhumane treatment of Black men and women in medical research specifically. In the 19th century, prominent physicians sought to establish the physical peculiarities of Blacks that could serve to distinguish him from the white man. And I'm putting those quotations because that's what the article quotes. Now, such peculiarities included thicker skulls, as Pei mentioned in the beginning, and I just want to give you guys a little bit more in-depth understanding of some of why the medical field is unacceptable to people of color currently. So such peculiarities included thicker skulls, less sensitive nervous systems, and diseases inherent in dark skin. And the pioneer of this was Dr. Samuel Cartwright. And for instance, he wrote that Blacks bore a Negro disease, making them insensible to pain when subjugated to punishment. And other physicians believed that Blacks could tolerate surgical operations with little, if any, pain at all. Now, well into the 20th century, now we're going centuries now, researchers continue to experiment on Black people based on based in part on the assumption that the Black body was more resistant to pain and injury. And the military covertly tested mustard gas and other chemicals on Black soldiers during World War II, and the U.S. Public Health Service, in collaboration with the Tuskegee Institute, studied the progression of untreated syphilis in Black men from 1932 to 1972. I don't know if there are a couple of you on the broadcast. I'm not trying to put any age on anyone, but some folks were born who are watching this right now or will watch that, were born during that time. That is a very current time. And our medical field is based on this ideology that Black folks do not feel pain. We're able to test on them any which way we feel. We're able to engage in unethical practices and justify those unethical practices because they're different and they have thick skin, thick skulls, and there's an inherent disease. That has not been debunked in the medical field yet. So when we're talking about individuals who are engaging in the medical field, we also have to talk about the training of practitioners believing the centuries of lies that have been justified as a means to establish the inhumane treatment of Black folks in this country. Now, I lay that as the foundation, and I'll leave you with this last thing because I don't want to take up too much time. Anti-Black ideologies affect all people of color. Because if you don't liberate Blackness, if you don't liberate anti-Black ideologies, everyone who is a part of a protected class will deal with what anti-Black rhetoric looks like. Thus, we have an Asian woman who was terrorized because she wanted to do the right thing for the community. These are anti-Black ideologies. They're not just anti-Asian, they're not just anti-LGBTQ, they're not just anti-protected class. These are all rooted in anti-Black ideologies that built the systems and structures that we engage in. Thus, when we talk about systemic inequities, we need to understand the root of the issue. Now, that is very complex and it's super large, and it's something that I'm constantly bringing up at the county, because if we really want to establish change, we need to look at what is the historical context of these ideologies, how do we dispel them, and then how do we create new systems and structures like our doctor did, bringing community in, bringing folks who have that technical knowledge and that technical expertise, and allowing for them to not just have a seat at the table, but be able to speak while they're at the table. So I'll leave that there. Oh, and one more thing. This year's Black Maternal Health Week theme, and I promise I'll leave you with this after this, is our bodies still, capital still, belong to us. So for every single woman who shared your story, your truth, I validate you, and your body still belongs to you. Continue advocating, continue fighting, continue speaking truth to power. And eventually, I believe if we come together as a collective with our allies, we can make this country change and really think about what it means to be women of color, people of color, and all of us live in a way that champions our lives and really understands our lived experiences. Thank you so much.
Wow. I knew you'd be keeping it real. And thank you, because I was nodding and I could see some of the other speakers nodding and saying, yes, this is talking about the root of it. I mean, thank you, because placing it in the history, placing it in a place of understanding is critical. It's not enough to make policies if people don't understand where we're coming from. And you just gave us some tough talk, which we need in the county. We pride ourselves, and sometimes we often rest too much on this notion that everything is fine in Tompkins County. And your job is what you've done tonight, is to remind us that no, we have work ahead of us. And there's that encouraging note, and I thank you for that someday we can achieve that if we keep working together facing the reality of this problem and where it's come from. So thank you so much, Charlene. We're excited to be working together with you as a county and in your office to help to actualize some of those dreams. And we're watching out for this programming that's coming up out of your office. So thank you again. And thank you to all of our speakers. Thank you for your courage, your boldness, the reality that you've given us in looking at all these different areas of our lives as women and so on. So we are calling on anyone in the audience who might have a question, a comment, an experience that you want to share with the commission. However, I will start off with a question I received before the meeting, which was, what from your own, all your experiences, what key recommendation, lesson would you want to offer to women? If you had to distill some of this to a takeaway that would help to empower people's voices, and make a change in these problems, what is it that you would suggest or propose? And so, who wants to start?
Crack at that. And then
Okay.
Miss Peaches, do you want to go before me?
Miss Holmes,
Okay.
you go ahead, please.
So if I had to distill anything for the women who either never experienced, right? Because I want to talk to all women. Either you walk into a place you've never experienced discrimination or bias, or you walk into a place and you always experience discrimination or bias. If you are someone who doesn't, use your voice for those who haven't, right? If it weren't for the voices around these women, they wouldn't have been able to get certain things done. The advocacy piece is very, very important. Your lived experience is not doctrine. Just because you've experienced something doesn't mean that everyone is experiencing it the same way as you. Get out of yourself and advocate for others. That's for those who don't experience. For those who do experience discrimination, believe yourself, believe your body, understand. We as women, and we are so intuitive. We know when something's wrong. We know we can pick up on senses super quickly, and believe that, and be okay advocating for yourself. A lot of women have some issues, at least some women who I've spoken to, a lot of women who I speak to have issues speaking up for themselves. They feel silenced. They feel like their voices aren't heard. Your voice cannot be heard unless you make it heard. And whatever consequences come, Dr. Josephine, I find you to be a trailblazer. You told them no. Yes, there were consequences for that, but the consequences are far less than you sending people to a practice that was unsafe for them. Right? So balancing the two. Sometimes your voice is going to bring some friction, but if it brings friction, that's usually an indication that you're in the right direction.
Thank you. Thank you. That's encouraging. Yes. Miss Gillette, did you want to go next? Yes. Thank you so much, Charlotte.
You're on mute, Miss Peaches.
She is still muted.
Am I on now?
Yes.
The idea of advocacy is to bring a witness with you when you go places, especially if you've already had an experience at that institution, to bring somebody with you who could witness what's going on, who understands the discrimination that goes on, and who could be somebody who speaks for you or helps you write the letter or affirms that what happened. That's most important, because this whole idea of like the hysterical woman, and certainly the hysterical Black woman, who being gaslighted by the medical profession is prevalent. And so if we can have somebody with us, that's a big deal. Everything about what we were saying, and certainly what you were saying, Charlene, it reminds me of the book Medical Apartheid, right? Unspeakable things, absolutely unspeakable things that have gone on. And I sit here, and as I listen to each and every person, I keep thinking, like, what century are we in? That's what I keep thinking. What century are we in? And nothing is going to change without somebody moving it to change. It just doesn't happen that way. So that's what I wanted to add.
Thank you so much. Thank you so much. Who wants
And
to go
I'm
next,
sorry,
Karen?
one more minute. And also, don't, if you can, I am not afraid to call things what they are. I have said to people outright, please tell me this is not a racist issue. Right out front, because it shocks them, and I'm not afraid to tell people what it is. And if you can muster that up, do that as well,
Thank you so much. Dr. Brown?
I was just going to say, I think it is really important to trust yourself and find your voice. And one of the things that I had to do with my wife, because her primary care person they were kind of like sloughing everything off and blaming it all on one thing. And I finally had to go and look her in the eye and say, I have known this person for 30 years, and I am telling you, she is not okay. And it wasn't until that moment, because we'd been in over and over, that I got her to listen to me. But I think it's so important that we do find that voice. And if you can't yourself, because I think it's also important to realize that there's such a power dynamic difference going into the healthcare providers. And it's complicated, it's confusing and all that stuff. Take somebody with you that can do that, or who is a good advocate for you. And I would say to tell women to empower themselves, be okay with your voice shaking until it's not. Do you know what I mean? Like, get the courage that you can. And an experience that I had that I didn't get a chance to share, and I won't go into it, but it was definitely an experience between one doctor who was uncomfortable with my lifestyle and couldn't bear to talk about it, and one who was. And what I was shocked, because I feel like I'm somebody who stands up for myself and advocates. I shut down and thought that one who was biased against me was my only choice. So I went home at 36 years old, still thinking I wanted children, being told I either had to have a hysterectomy or go on the pill and just deal with it. And yet I went home and was deflated by it. So imagine anyone experiencing discrimination or whatever, you just shrink into that. Somehow you have to deal with that. And it wasn't until my wife said, there are a lot of other doctors, go see someone else.
Right.
And when I did, I got 7 different options to deal with, and someone who respected me and my wife and a different thing. And I guess it's just so important to realize that you can choose someone different, and that you don't have to do just because that one person said that. But I think healthcare, especially as we age too, I just want to throw in is that sometimes there's this thought that, the doctor is the only one who has the knowledge, the only one that knows what's doing. So who am I to question that? And so it's so important to know that who am I is that I'm a partner in my health. And if you can't partner with me, then we need to seek somebody else.
Thank you so much. Thank you very much. Is there anybody else who has something to say before we go to the next question?
I would like to, I think it's important that we always go in my house, each one teach one. So for me, the biggest takeaway is to empower my children and empower those who are younger than we are, to equip them so that they know that their voice matters, that they have a right to speak out, they have a right to ask questions. So even now when I take my children to the doctor and I say, what questions do you want to ask? It's, Mommy, can you ask him this? I was like, I can, but I will not. You have to ask, you have to be the one. So again, it's just also looking down the line to then bring up young men, young women, who can then have a voice and feel equipped to ask those tough questions as well.
Thank you very much. Thank you very much. is that I would just add, I think, to the excellent point that you've all made, and this is something I just started doing very recently. Think about the name that you also want to be called when you're at your healthcare practitioner. Very often we just submit, and particularly for many of us who are from a different age, a different country, and so on, there's a feeling that you are further made an infant, infantilized, when you're at your healthcare practitioners. And we submit to that. And I recently, looking back, and as I prepared for this program, a few weeks ago, decided to go back and change my name, my preferred name, with my practitioners. And it might be that you want to be called Miss This or Mrs. This, whatever it is that makes you feel more confident, more, because, and creates a sense of, changes the kind of relationships of power that often silences us. And so I did have the pleasant experience of, for the first time, being called a very different, by my last name, which I wanted to be called. And I didn't mind before that. But I realized that it changed it for many of them. It didn't change it in my mind, whether you called me Pei or whatever. But I realized that it worsened how I was treated. And so I decided to make that change. And so I've been encouraging many of the women of color with whom I work and say, what do you want to be called by your doctor?
Yeah.
And you can choose that option when you go there and say, I prefer to be called this. And I think that's important. The second thing I would also suggest that's very practical is learning to document it. Sometimes you don't want to necessarily engage, fight, but you want to pull it together in your mind. And it's just worthwhile sitting down. And when you put it and say, oh, this happened on this day, this happened at this time. And then you find the courage to say, okay, I have it written down. I will send it to the practice. It's not because you are going into litigation, but you want to just begin to create a practice. And by the time I was preparing for this program, I could find 5 letters that I had written to different doctors, and it pulled everything together. Things I had forgotten, would not have the time to find out. They were there in a letter documenting this. And I realized that either you write it, you can have somebody else help you put it together. Sometimes sending that short letter to say, I'm not comfortable saying it verbally, but I was very uncomfortable with how I was treated when I came to the practice. I was, left in the waiting room while, things like that.
Yep.
Sending a short email, putting it in the portal often makes them sit up and take notes and change the way in which they actually deal with you or behave. And sometimes it works. Sometimes it gets them scared, like my dentist, when I complained, that I stepped out for 10 minutes and he decided to pull out my young son who was in elementary school. They took him in while I was outside with a phone call, and he decided to pull out his 2 teeth. I walked back in and I was like, where's my son? And they said the doctor took him in there. I thought they were chatting, so I ran in there. He was just such a young little boy. His eyes were big like saucers. He was scared. And I knew, would it ever have been done to a white woman? How dare you do that to my son? I didn't say anything while I was there. Calmed him down. It was too late. They were already pulling out the teeth. I got home and I called him. I said, I cannot believe you did this. This was an infringement in every way of my right as a mother. You did not discuss it with me. How could you pull out the teeth of a little child without the mother being there? And I was outside. He said, oh, I thought, I apologize. I'm sorry, I just thought this. And then when I wrote, I said, well, I wasn't just so you remember, don't do this again ever. They mailed back our entire records. When we tried to get an appointment again, they said we didn't exist in the entire thing. We've been there for like several years. We did not. They said you don't have any appointment. They canceled every appointment. So often there are consequences. But for me, writing it down was very critical and useful. So thank you. Now we have a question. First, before the question, I'm going to read. This is a very heartbreaking situation. Miss Aponte is sharing her story in the chat, working in healthcare. She says, in July 2023, I had to obtain an order of protection against my soon-to-be ex-husband after a very public incident which our children witnessed. A week later, the benefits director called a meeting to notify me that my scheduled vacation was cancelled and I could not take any more time off, even unpaid, because I had just taken a 4-week leave of absence. Now, I'm not sure about the rest of this, but
And her story continues here that she had already cut back on her hours despite having a waiting list. A lot of women patients in this town love Dr. Aponte and would have waited for her to come back. She was burned out with the for-profit healthcare system. She was told she could not take any further time off for the next 5 months. And she writes, knowing full well I had become a single mother overnight and was dealing with trauma, my choice was to work without any time off until December or being terminated. So I gave my notice.
Wow.
And I have to say, our community still has not recovered from this. It is very difficult to get a primary care physician, much less someone like Dr. Aponte. She is young, energetic, brilliant. There's something wrong when the system moves someone like this out of healthcare. Someone who's so desperately needed.
Yes.
And should have been given a chance to stay.
Wow.
And think of all the thousands of patients that can benefit from her care.
Wow.
This
Dr.
also makes me think about what type of systemic structures are present within your organization. So as a practitioner of diversity, equity, and inclusion, we see that there's an attack on DEI, but there has been some established DEI in certain healthcare spaces and in certain academic spaces. I think that when these types of situations happen, like we're talking about the HR benefits director. Like, we're not talking about a senior level manager. We're not talking about someone who sits on the cabinet. At this point, if I know I'm an established individual, I'm going to the top, right? And I'm going to use my voice all the way through while I'm in the system, at least to advocate and get the full stamp from the top person before I listen to the person who's in the middle. And I'm not saying that Dr. Aponte didn't do the right thing. I'm just giving a little bit of insight into some of the ways in which we can use some of these systemic structures to our advantage. We're there not to be discriminated against. There are laws that organizations are not allowed to discriminate against people of color, people from protected classes. These are Title VI, Title VII, ADA, human rights. There are rights, right? And these particular organizations have agencies that they must adhere to. If you don't understand that as someone who's advocating for yourself, you will go into these spaces and most likely feel a little bit bullied, and you might just listen to whatever policy that person made up in the moment, right? This sounds like this HR benefits director just felt like this doctor couldn't take time off. Where is the policy? Show me in writing. When did it get passed? Can I talk to the senior managers? Go up the line, because this is where, for a DEI practitioner, I'm extracting where the bias happened. And so I'm just giving you guys a little bit of insight into my extraction. I'm looking at who made the decision, what was the decision based off of, and who was the senior leader who signed off on this. Those people need to be held accountable before they're able to say, you're not allowed to take any time off, right? You're not allowed, getting threatened that you have to work or be terminated. Who said that? Why and what gave them the right to say that? You need to see the policy and the procedure that gave them the right to say that. Otherwise, that is a bias incident and you have reinforcements. I don't mean to speak so bluntly, but I feel like it's a lack of communication that we have, where HR is definitely there for the organization, but you need to advocate and understand your policies and procedures, because most of the time these are people just feeling like they can make the decision in the moment because they felt empowered to do so. And if I'm wrong, Dr. Aponte, forgive me, but that just rattled my nerves and I just wanted to give a little insight about it.
Thank you. Yeah,
Thank
I think
you.
that's
And I'm
exactly
sure.
why we need your advocacy and expertise.
Thank you, both of you, Dr. McAllister and Ms. Holmes, for your response to this is heartbroken. I'm reading that Dr. Aponte said, she sees patients who see her and hug her and miss her, and she's absolutely heartbroken. And I think what strikes me is that typically these things happen when we're at our most vulnerable. And it's when it's most hard to find time to be able to, on your own, take these kind of steps that you would take. And from the story that she's written, it was certainly a really difficult period of time. And that is when you need an organization, you need mentors. I spend a lot of time writing legal cases for people, battling with them when they are at the most tired and vulnerable. And sometimes even just writing their story takes a lot of work. How much more the time to find out who's responsible to battle. And this is where we need to be able to support each other and stand in solidarity. And we certainly need more support from the county that helps to support people who are having to fight these battles, because it takes a lot of energy. Dr. Aponte, I am reading this and I am just distressed. We're sad. We are sorry that you've had to go through this. It's a big loss for our community. And I hope that this is something that might be able to change as, as time goes on, that we're able to kind of find a way to fight so that your patients once again have access to the doctor that they love and who has cared for them. And that somehow we can find a way through these stories to make changes in how we support people when they're at their most vulnerable. We're almost at our time. We actually are time. And I think we just have one question that we're going to quickly look at. As a person interested in healthcare accessibility by refugee women, I'm curious to know about any work or initiatives being done with immigrants or refugees. If one person wants to respond to that, we'll quickly take it before we call this event to a close. I will quickly throw out that I know that maybe not just one particular work, but I know that in support of refugees, particularly women who are refugees and going through difficult, situations to do with accessing care. I know sometimes the Advocacy Center is a very key center of support and helping to open the door to other areas of support in a community. I know also that Catholic Charities also has some dedicated resources to support people who are working with refugees. I'm also aware that Ithaca Welcomes Refugees is another organization that has been very, very much putting itself out there to help to settle refugees, making the transition, and also working with them in accompanying people to healthcare sessions, interpreting with doctors, and their particular individuals who have done a lot of work in that area. One of them was Edith Johnson, who has left the community now, but who did a lot of work with refugees from the Burmese community in Ithaca. So there are these different areas of support. And if anyone wants to add a particular one, I'm happy to hear that before we close our meeting today. All right. It seems that we are at 3 minutes past time, and I cannot tell you how thankful we all are to you, our speakers, and certainly the Human Rights Commission. The commissioners have been on the YouTube helping to reach out and speak to individuals there. And we have a reminder from one of our manager of our soon coming community survey, asking us to watch out, to tell you all to watch out for the survey. The person helping us to manage this will be Yolore Irawele, who coincidentally is my daughter, is helping to get our first ever community survey out in a few weeks that will cover all these different areas of experiences of county residents. And we hope to be able to use the results of that survey to base some of the policy recommendations that we have. I also want to give a special shout out to Rob Henry, who has been amazing. He works with the county communications department. He has just done a great job in helping to make this entire event possible, sorting out our technical needs. I want to thank all of you, our audience, who have listened patiently to us today and have sent comments on the platform. Bless you all. Thank you so much from the Human Rights Commission. Look forward to seeing you at our next Unmute Yourself events. Stay well, stay strong, stay fighting. Thank you very much, women.
Have a good night.
Have a good night, everyone. Thank you.